Oh boy, is this an important page. Oscopies. Let me just say a couple things about oscopies, because it's all the same for no matter which oscopy it is. It doesn't matter if it's a laparoscopic surgery, bronchoscopy, laparoscopy, bronchoscopy, hysteroscopy, colonoscopy, endoscopy, colposcopy, it doesn't matter. Whatever oscopy procedure it might be, there's a huge risk of perforation. We make you sign a consent that says that. It doesn't matter which oscopy procedure it is. The risk is huge for perforation. The only good news here is typically whatever perforation occurs, and it happens quite a bit, more than you'll ever know, it's usually microscopic and the body heals itself. We nick bladders, we nick bowel, we nick all kinds of stuff. Because what are we doing? We're using incredibly sharp instruments poking holes in you. So I tried to make you understand this by describing a laparoscopy surgery. So I'm just going to play a little bit with these things here. Let me just show you what I mean, because I think it's really easy if I just show you. Okay. When I do laparoscopic surgery, first of all, we're going to blow your little belly up with a bunch of damn gas. But let's just say we have 3 instruments, okay? Maybe we have a light, we have a trocar, who knows, 3rd instrument, okay. Typically, for a lot of the female shit that I would be interested in doing, I'm going to make a tiny little hole with one of these little gadgets at the top of the pubic bone. I'm going to make another little hole at the base of the umbilicus and another little hole off to the side somewhere to do whatever I'm doing. Maybe I'm tying tubes, who knows what the fuck I'm doing. Okay, so whatever. All 3 of these are super freaking sharp. So I could have nicked the bladder here, could have nicked bowel here, could have nicked liver here, could have nicked spleen over there. In other words, beloved, your body doesn't say, hey, how you doing? You coming in, huh? Let me scoochie out of the way. Everything is all mixed in there. If you guys were fortunate enough to see a surgery, it really is illuminating because it's all mush. It's not easy to kind of tell what you're doing in there, especially for your resident. So you're going to get perforations all the time. When you get a perforated patient, usually it's no biggie. However, for you, you don't know that it's no biggie. So you have to act on every little your that you might get at the top of that page. If you look at what I wrote, it says abdominal pain or complaints after an oscopy are OMGs. Okay? So my stomach hurts. You know how kids are. My stomach hurts. Adults. I'm cramping really bad, like really, really bad. It could be that it's gas, but it could be that it's a perforation. Now, how will you ever know? Well, this is what I tell you, just like outcasts. Outcasts for the gas. When I move, you move. When I move, you move. Just like that, okay? What am I saying? Gas pain moves when you move. Outcast is gas. Your pain ain't gonna go nowhere with a perforation. It ain't gonna change in its intensity. It's not gonna get worse or better depending on your movement. Do you see what I'm saying? This is important, and you don't know it because you're so young. But gas pain feels like a knife. So your patient's going to say it's severe. And if you're not smart about gas pain, you'll assume it's a perforation and freak out about every little thing, when reality is all oscopy procedures give you gas pain. because we blew your belly up really big with gas. So all oscopy procedures will give you gas pain. But you got to figure out, is it gas or is it a perforation? Well, a perforation is going to be very clear because it's not going to change if you change the patient's position. It's not going to get better. It's not going to improve with ambulation. They're not going to associate it with passing gas or burping. It's just constant pain. But don't get it twisted. It don't need to be severe. It can be in a man, because men don't call stuff severe. It could just be, yeah, I'm having a little bit of pain. Well, where is it? It's kind of like on this side. I wouldn't mention it, but they said to tell you if I have pain. Well, does it change at all? Is it constant? Yeah, pretty much since I got out of surgery. Oh, okay. Do me a favor. Stand up and walk a couple steps. What's it feel like now? The same. Oh, okay. That's not going to happen with gas pain. It's going to change one way or another. Okay? So pain, gas pain changes with ambulation, position changes, movement, not perforation pain. And perforation pain is really abdominal. It's not chest, whereas gas pain can be sharp chest-like pain, just sharp knife-like chest pain. Okay. Okay. Now, I put them all together. For this lecture, it's easy if I just say everything oscopy goes with this. Almost all of these oscopies, and definitely all the ones on this page, almost every oscopy procedure needs you to be NPO after midnight. Every oscopy procedure needs you not to have taken Motrin or Aleve or ibuprofen within the last couple weeks. Every oscopy procedure typically is going to require that you ask about an iodine or shellfish allergy. And you see that's written for you. It's already written. So if you look at the very first oscopy, all that's written. No gum, no smoking, no NSAIDs, no anticoagulants. Check iodine out. All that's written for you. Almost all oscopy procedures remove the dentures. Now, any oscopy procedure done from the sternum up and the entry was through your mouth, you got to check for a gag reflex. When should a gag reflex return? Where's my belt? It's not a bowel sound. Shit. It's a gag reflex now. All we did was spray the back of your throat with anesthetic spray. So you ought to be able to swallow and have a gag reflex before you leave us. And most of the stuff is outpatient surgery, remember that. So we're not going to discharge you if you can't swallow. So think that through, because remember, all your recoveries are done within 2 hours. So if you've been kicked out before the 2 hours, which happens all the time with most of these outpatient procedures, then you must have had a gag reflex, because I'm not going to let you go without a gag reflex. You're at high risk for aspiration, correct? Okay? Now, you're not about to offer no juice, water, drink, nothing, unless you check it. Okay? Look what I wrote. I wrote so many really good things for the babies. I wrote something that is important to distinguish from other things on this list. If you look under endoscopy / EGD, then I put another procedure called upper GI. These are not all created equal. The upper GI, everybody, requires a barium swallow. What you had to know about barium, and it's in the little paragraph, you cannot get it if you're pregnant. If you've had barium, it acts like concrete in the human body. So you had to push fluids, take laxatives to prevent constipation or bowel obstruction. Okay. All right, so you got an idea of what we're doing for all of these. Now, I put 3 big ones on your test. On your handout. Obviously, the EGD is the #1 evaluation of GERD. EGD, highlighted. #1 evaluation of GERD and an upper GI bleed. #1 evaluation of GERD and an upper GI bleed. So that's the EGD. It's a standard of care. Okay, while you run around with your heartburn that's been going on for 2 years, you should have had an EGD by now. Okay, all right. Now, the next one, and do not confuse it with this. Do you see how you have an ERCP? There's something also called an MRCP. I want you to write that in the margin and put non-invasive for MRCP. And then, of course, you know an ERCP is very invasive. What I tell you about the ERCP is it basically is an endoscopy. Okay, so the MRCP uses an MRI instead of an endoscopy. It's non-invasive. It does use a dye, but it's not invasive. It's just not going to be like an ERCP. It's obviously safer. You can't use an MRCP in anybody pregnant, of course. And they have to be NPO for 4 hours. Remember, just like over here, MRI and MRCP does not use contrast dye. Neither does an MRI. So do the MRIs use dyes? Yeah. What kind? Not contrast. So write this down. Okay. Gadolinium is the type of dye. It is not a contrast dye. That's what an MRI is using for this MRCP. An ERCP uses contrast dye. Every one of these uses contrast dye. Every last one of these on this page. All these oscopy, endoscopy, and ERCP, and EGD, and all of that's going to use a contrast dye. Okay. Now, for the endoscopy, EGD, upper GI, blah, 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 the ERCP has one more additional complication, because typically the complication of the one above, endoscopy, EGD, upper GI, blah, 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 you'll see I wrote perforation, aspiration, and infection. But if you look under ERCP, you will see the complications added one more. What did they add? Pancreatitis. Wait a minute, I thought you were doing it to figure out if I had pancreatitis. How in the hell did I end up with pancreatitis after you were done? Easy, because the nurse didn't do the proper teaching. So let's explain. This endoscopic retrograde cholangiopancreatography, right, is used to look at the liver, gallbladder, pancreas, and biliary tree. When we do this, we go through your esophagus and we're looking at all your different structures. Well, if you just think that through and you think what itis means, it means inflammation. So just you going down there with the sharp-ass instrument all up and around my bile area, my biliary area, can cause my pancreas to become inflamed because you were in there with my organs. Now, it's not going to be a problem if the nurse did the proper teaching. How do I know? Because I had a student that got rebound pancreatitis from this damn test. And I asked her, I said, "You got pancreatitis?" She called me. "You got pancreatitis?" I said, "That's awful." I said, did they make sure you didn't eat after your ERCP? Ain't nobody told me I wasn't supposed to eat after the ERCP. I knew I wasn't supposed to eat before the ERCP. Look what I wrote. I wrote that if you look at this patient post-procedure, no solids times what? 24 hours. She left the short stay area around 2 o'clock. She had eaten by 8 o'clock. That next morning, she was back in the hospital with pancreatitis. Because when you eat, you stimulate production of those nasty little enzymes out of the pancreas, and they're going to auto-digest if you have inflammation. No one told her that. I said, "You didn't get any kind of discharge instructions on the handout?" "Girl, no. They gave me the little typical pink thing. Return, follow up with your doctor." I believe it. You got to teach this. No solids times 24 hours. It's not true for anything else. It's only true for ERCP. Now, colonoscopy is easy. Your life, you already know what this is. So your life is to remember when we do it. We start at 50 for no risk, low risk people, and we do it every 10 years. 50 years old, every 10 years. If you're African American, 45 and every 5 years, because they have such a higher rate of colon cancer. Normal, low-risk patient, 50 years old, every 10. Family history, African American, or polyps, every 5. So African American, family history, or you have polyps, it's going to be every 5. Polyps is the #1 risk factor for colon cancer. Same shit, different day. You got contrast dye, you got to remain NPO, except for clear liquids the morning of. Now, make sure you know about that prep. As you know, we need a bowel prep with a colonoscopy, but not with a sigmoidoscopy. A sigmoidoscopy needs enemas. A colonoscopy needs a bowel prep. A bowel prep is a lot better than it used to be because now they use laxatives too. So that was a big deal. They started using laxatives, life got a lot easier for the person trying to do a bowel prep. Okay? Now, the #1 question for the nurse to ask this patient when they come in for this procedure: "Sir, what color is your stool?" The answer better be clear. No other answers are acceptable. Because then I just tell you all GI is dirty. What if they perforate this patient? If they perforate this patient and their stool was not clear, well, they're running around basically with a potential for peritonitis. Any perforation is going to give you peritonitis if there's stool involved. So your bowel prep is drink until clear. Gas pain is very common. On your pink packet where it says gas pain common, remember how we cure it. Ambulation. Some of you are going to be in trouble with me if you pick simethicone. That's a good drug, and yes, it does work. But remember what I taught you? Basic care and comfort means medications last, nursing care first. So ambulation is the number one way. Now, this enema, I promise you, you got to know the position for an enema. I promise you that. Everybody in here. I also promise you that if barium is used as a swallow or barium is used as an enema, it doesn't matter which one, by the way, barium swallow, barium enema, it's going to make everything white. It makes your stool very white, like concrete. It can cause a bowel obstruction because it's just like concrete in the human body. And this white stool lasts for about 3 days. If you don't tell your patient about this, they're going to freak out. And you know that. Okay. Next on the lineup, medication administration. Injections. Very, very important stuff here. Oh, yes, baby.
For the bowel prep, is that neomycin?
No. A bowel prep is where you drink all that crap, that fluids, go lightly.
Oh, okay. I'm sorry.
That's the alcoholic.
No, we had a question on page 4,000 that says, how do you sterilize, clean the bowel? And if you-
Bowel prep is not sterilizing the gut. Sterilizing the gut is neomycin. That's on your medication packet as clear as day. So on your medication packet, under neomycin, it's going to say sterilizes the gut. That's not the same thing as a bowel prep. Yeah, no, it's a little different. And we do that for the alcoholic because of ammonia. And for some ammonia levels, yeah, because it kills all the bacteria. It's going to kill every bit of bacteria. That's different from emptying the gut. A bowel prep is just to empty it. Yeah, you're welcome, baby. They're very important. Practically speaking, I have written a lot of things for you already, hooking you up. But a picture speaks 1,000 words. Do you see the person with, let me see, 1, 2, 3, 4, 5, 6, 7 patches on them? That's what people are saying is going on in your arena, in your field of work. They are saying that these patients are getting overdoses and they're running around here with 4 and 5 Exelon patches on at once. And who's catching it? The aide. So if you're an aide, you probably have seen this. Now, what you want to understand, in case you come up out of here and get clueless, you committed fraud, a complete felony, if this is your patient. Can someone tell me why? Because you signed the MAR that you removed the old patch. If that's a Medicare or Medicaid patient, that's a federal insurance. You just committed a federal offense. These nurses out here doing this dumb shit, that's fraud, is a felony because it's Medicare, Medicaid. You are literally saying in a Medicaid, Medicare, medication MAR that you took the damn thing off and you did not. It would be better if you lied on a private pay. At least it's not a federal offense. But you're crazy. You got to check these patients when you get them. The hospital nurses, you guys that go right to the hospital, you're going to get those admissions every day. You're going to go, what the fuck are they doing at these nursing homes? They're going to leave the nursing home, and they're probably going to come for confusion because they have 50 patches on them. That's why they're confused. This is why I won't put my family in these places. No way. Now, if you look at the next one, it says, now I love this, do not place over dense hair. Oh my God, that's terrible, isn't it? Doesn't he look hairy? But do not shave the hair. So you're thinking, well, what do I do? Well, put in quotes, clip the hairs only. Clip the hairs only. Don't shave. Do not shave. Now, when we take the patches off, you got 3 things to remember. On this page, it says, do remove patch before an MRI. You got to remember before AED as well. Remove the patch before an MRI and before the AED, the defibrillator. You also have to remember when you take it off to fold it on itself. That's on the pink packet. To discard patch, fold on itself and throw in Sharp's container or flush down the toilet. Now, your nurses are stealing these, and they're stealing Sharp's containers to get them. It is disgusting. It's so dangerous, but they don't care. They're also stealing them off the patients and putting gauze with tape over it. Your actual patient may have told you they're in a lot of pain, and you're thinking, well, what the fuck is that about? You got a fentanyl patch. No, they don't. They have a gauze with tape over it, and the patch is on the nurse. That's what you better look at. Watch what you're doing. Your patient's still in pain with fentanyl, that don't even make sense. Fentanyl is the most powerful pain medication on earth. Remember, it's called Duragesic. It's a last resort, and it's for terminally ill patients. As you know, it is not for post-op. It is not a post-op drug.
I have a question. Nothing stupid. How are things like heroin dealers getting it?
Oh, honey, they take that little buckle and all the, even the patches and stuff, and they chemically mix it and fix it into powders.
Okay, so it just breaks up the last.
That's what you call a trap house, boo. They cook it. Yeah, that's another lecture. They baking it, baby. They baking it. Girl, the stuff they be doing ain't even right. Okay. They cooking in the kitchen. That's what they mean. Ain't no song about no cooking. That's cooking in the kitchen. Okay. Now, it's crazy, isn't it? It does. It makes you wonder, how are they getting the stuff off the patch? Yeah, they're doing all kinds of shit. Okay, now, nicotine patches. Y'all see that? What did I write in big capital letters? You will not believe how many people smoke with this damn patch. They are going to cause a stroke. They don't know that. My own cousin who lived with me didn't know that. I'm looking at her hit a cigarette in the garage, and her monkey ass has a patch on her arm. I said, whoa. Couple things wrong with you. You finna burn down my damn garage, number one. And number two, why is you smoking with a damn nicotine patch on? She said, because they didn't tell me I couldn't smoke. She's ready, my cousin older than me, so she want to fight me for every little thing. Bitch, they didn't tell me I couldn't smoke with no patch. Here your little Nancy nurse ass come talking about I can't smoke with my patch. You overboard. Oh, really? I'm overboard? Okay, bitch, let me show you. So I pulled it up on a computer to let her see. Do not smoke with this patch. She was like, oh my God, why them nurses say? Because they not overboard, boo. They don't love you like I do, boo. Okay, so please tell your patients no smoking with the damn patch, okay? Now, Exelon patches. I want you to highlight. Change it daily. Change it daily. Obviously, it's for dementia. Okay, so that's good. Now, these creams, rings, and things, okay? Let's do the creams, rings, and things. See, we're getting through this damn board. Creams, rings, and things. First of all, nicotine gum, if you're anything like I am, you didn't know this, because I didn't know this. First of all, our poor president, y'all know that man be smoking. And when I went to the first inaugural event, you ever seen him? Oh, yeah, I have. Oh, yeah, Obama smoker, he's worse now. I know things about the man y'all don't know. Just saying. Girl, I know everything about him. I read up all about him. So let me tell you what was going on at the inaugural event. He was chewing the gum, and he just kept chewing the gum. And I got it now. It's like every 5 minutes I'll see him put this new piece of gum in his mouth. Look what it says. you have to chew 10 to 15 pieces a day. Yes. So it's kind of like every time you would have lit a cigarette, you put a new piece of gum in your mouth. That's how you got to think of it. It's going to help you on this exam if you remember that. Every time you would have taken a cigarette, you just put a new piece of gum. So what does it say? Every 1 to 2 hours, you need a new piece. No smoking. No, God, no. Now, should I say it? Now, the Chantix, that's one I would put a star by. That's a wonderful drug, by the way. My patients stopped smoking on that drug really well. Chantix, highlight the shit out of it, is the only medication you can smoke with. And you can smoke as you wean off for the first week. However, for certain people, there's an increased risk of suicide and nightmares. I just say that's because they stopped smoking. Cigarette was keeping them calm. So, for real, you had to know that. All jokes aside, you had to know. Chantix has an increased risk of suicide and nightmares. So you're thinking about, you have to think about, what are you doing? Maybe your resident means well, and he's on this like rampage to get everybody to stop smoking, and you got lucky, like a lot of my nurses, you got a job in the outpatient clinic. Boy, are you blessed. 8-hour days, 1 hour of it lunch. So you got this kick-ass job, you're happy, no weekend, no holidays, but your residents rotate through and you get new residents every month. And that's fine, but this one is really excited about getting people to stop smoking. I ain't mad at him. Only problem is, he keeps writing for Chantix on everybody, and you happen to notice the patient that he wrote it on is on an SSRI. Oh, ding, 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 ding. Why would you give this medicine to a patient with an SSRI? Because that means they must have had a history of depression. And if this commits suicide, if this drug can make you commit suicide, well, this would be malpractice, because you did not question that order or prescription. So you're not going to get no Chantix to nobody with no damn SSRI, or no history of suicide, no suicide attempt, no history of depression, nothing like that. No, that doesn't even make sense. I chose who I gave this drug to very carefully. And I also want you to remember what else it says. They're going to report that they have nightmares. They're going to tell you, I got bad dreams. Oh, that's kind of common. Are you still willing, you're still okay with it? Yeah, I just thought it was kind of weird. All of a sudden I had bad dreams. That's common, okay? Now, here's the deal, y'all. And I'm not, I don't work for the drug company. 100% of the people I wrote this prescription to stopped smoking for good. 100%. That's crazy. Okay. I don't know why it worked. Oh, because of the commercial. Because your patient's going to watch the commercial. And they're going to say, suicide? Oh, no. What this bitch give me this drug for? The patients are watching these commercials. And when they say, there's a risk of suicide, they're not going to take it. So you have to address it up front. If you tell them up front, when you see the commercial, it's going to be scary. But know that nightmares can happen with this medicine. You can have freaky dreams, like the baby said. Or you can even have a situation where the commercial's going to talk about suicide. But you've never been depressed. I risk assessed you first anyway before I gave you this drug. You never had depression. You've never been on an SSRI. You're not depressed now. You just need to quit smoking. This will work. It works really well. Okay? Wellbutrin works really well. Just like that baby said. Of course, it's in your psych packet, but it works really well. Okay, so Wellbutrin is a smoking cessation drug, which you know is called Zyban. So look, underneath Chantix, put Wellbutrin. Same thing as Zyban. Now, next on the list, Emla cream. Remember, it says topical anesthetic. Oh, you're on break. Okay, last thing, highlight it. Look where it says apply a dollop 1 hour before the procedure. You got to know that. And a dollop is written there because a dollop is huge. It's a big glob. It's not a little, a nice little smear. No, no, no. It's like you took a big old spoonful and,
Sour cream.
yep, sour cream dollop of daisy. That's a good one. A big old spoonful, yep. So you got to use it generously. Then I want you to cover it with an occlusive dressing. It works better if you cover it with an occlusive dressing. Okay, y'all doing good. Go on your little break, walk around, jump up and down, find your life. I know, we're on the last mile. Thank you, Jesus.
What was the 6 centimeters before? I just read it in the packet.
5 millimeters was